Welcome to another installment of the Dutch webinar series. My name is Dr. Kelly Roof, and I'm a clinical educator here at Precision Analytical. And in today's webinar, we're excited to welcome one of our very own, Lindsey Szczepanski, who's going to delve into today's topic, progesterone resistance and endometriosis. We're glad you chose to join us to gain valuable insights into a more effective and integrative approach on this topic. Lindsey is a nationally board-certified women's health nurse practitioner since 2011 and has extensive experience in providing comprehensive care to women across all life stages. She has additional training in reproductive health, prenatal and postnatal care, fertility, and hormone replacement therapy. She's known for fostering compassionate and trusting relationships with patients and healthcare professionals by providing education and support. And she's worked in various settings from OB-GYN, family practice, functional medicine, and urogynecology with a pelvic floor rehabilitation program. Prior to becoming a women's health nurse practitioner, she practiced for 5 years as a labor and delivery RN. Lindsey has been part of the clinical team for Precision Analytical since 2021. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. It's really easy. Just click that link that we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to our entire educational library, including courses like Introduction to HRT, Mastering Functional Hormone Testing, and the Dutch Interpretive Guide, and one-on-one consultations with Dutch clinical educators. This dedicated support and education is, of course, designed to help you become the hormone expert. And if you have questions as we go, please submit them and we'll do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's a pleasure to have you with us, Lindsey, today. Now take it away.
Good afternoon, and thank you, Dr. Kelly, for that intro. Thank you all for being here today and spending your time with us. How many of you out there like to watch true crime documentaries or detective shows? Well, today you may feel like you're watching a bit of a mystery crime documentary as we work through a case called the Mystery Menstrual Mess, otherwise known as endometriosis. I'm kidding about the watching of a detective show today, but however, if you've ever worked closely with a patient with endo, you completely understand what I meant when I said it's a mystery and sometimes a mess when you're trying to figure out where to begin with your workup or end with a treatment plan. I've worked in multiple women's healthcare settings, like Dr. Kelly mentioned, and I've also even worked in a urogynecology practice that had a pelvic floor rehab program. And no matter what setting I worked in, women with endo were always a bit of a mystery. Treatments that worked fantastic with great outcomes for some would barely scratch the surface or control symptoms in another patient. In today's webinar, we will explore a critical yet often overlooked aspect of endometriosis called progesterone resistance. This may be a new topic to some of you. Let's get started. Just a friendly reminder that today's discussion is for information purposes only and is not intended to be a substitute for professional diagnosis and treatment. Here are today's objectives. After today's webinar, you will have a better understanding of what progesterone resistance is, diagnostic criteria for diagnosis, things to include in your workup, and different treatment options available. You will also review a couple of Dutch reports of confirmed endo cases and point out some markers of interest that will help guide you to develop targeted treatments. I think you will find today's topic to be interesting, but you will also leave with additional things to use in your toolbox when caring for women with endometriosis and more confidence in how to approach some of those trickier cases. What is endometriosis? Endometriosis is a complex and often debilitating condition where tissues similar to the uterine lining grow outside the uterus, causing chronic pain and fertility issues in patients. This misplaced tissue can implant in various areas of the pelvic region, including the ovaries, fallopian tubes, bladder, and rectum. Rarely is it located outside of the pelvis, but it can be located in other areas. The cause of endometriosis is unknown, though many contributing factors have been identified. There is no specific way to prevent endometriosis, and it can develop at any age after the onset of menstruation. Endometriosis is a chronic inflammatory disorder that disrupts the coordinated progesterone and estrogen response throughout the reproductive tract. We're going to be focusing a lot heavily on that area today. Endometriosis was once thought as primarily as an estrogen-driven disease because estrogen promotes the growth of endometrial lesions. However, more research has identified there being a shift from E dominance alone to progesterone resistance in endometriotic tissues as another major contributing factor. The endometrial lining of women with endometriosis behaves very differently from that of healthy controls. Endometriosis is more than just estrogen dominance being in the driver's seat. Many processes, such as the immune system disruptions, hormone alterations at the tissue level, genetics, environmental triggers, and more, are occurring simultaneously and can impact endometriosis development and progression together. Check out the article I posted on this slide to help kind of give a bigger overview of the many systems involved and even subsets of disruptions that occur under each of these umbrellas. Although many theories have been studied, there is still no single process that can explain all the aspects involved in this disease. There are many theories of pathogenesis of how endometriosis develops. The exact mechanism of origin and the progression of disease is still poorly understood, and we are going to focus on one subset of factors that is gaining attention: a hormonal imbalance in the tissues that occurs because of progesterone resistance. But I want you to be aware of these other theories because when you address multiple mechanisms at play, this will help with better symptom management for patients that are affected. Some symptoms. The most common and significant symptom is painful cycles. It can be debilitating for many. Women with endometriosis often plan their schedules, their work, their travels around their cycles due to the severity of symptoms. Be really suspicious of endometriosis being present when you're diving into the menstrual history if they start describing how they run out of PTO each month because they maybe can't get out of bed, or if they've refused to go to an event or travel because they were worried about bleeding or pain. Painful intercourse is also a common symptom. Bloody stools, which are less common, painful urination, chronic pelvic pain outside of the cycles. Women with endometriosis are at increased risk for anxiety and depression, and higher rates of ectopic pregnancies are also a high risk factor. So if you have an endo patient and a pregnancy is detected, you want to follow those beta HCG levels early on. If the beta HCG levels are slow to rise or not doubling every 48 hours in this population, you want to be on alert for an ectopic pregnancy. If you do a transvaginal ultrasound and their beta HCG levels were 1500 and you don't see an intrauterine gestational sac, this is a concern. Also, about 40 to 50% of women who are experiencing infertility are diagnosed with endometriosis when they go in for their fertility workup. Some risk factors: increasing age, alcohol use. If they start menses early, age 11 or younger, if there's a family history of endometriosis, low BMI, if they have prolonged menstrual flow, so if they're bleeding for a week or longer, or if they have short cycle intervals, so maybe they get a cycle every 24, every 25, 27 days, they're at a higher risk. In some very small studies, they noted a link with increased endometriosis with women with red hair color, blue or green eyes, and freckles were also reported to have increased odds of the diagnosis. As more genetic testing improves over the years and more phenotypes are identified over time, it will be interesting to see if some of these phenotypes are more susceptible than others. Again, those were really small studies. I just wanted to point it out. How is endometriosis diagnosed? Diagnosis is typically based on the combination of presenting symptoms, menstrual history, physical examination findings, and sometimes surgical findings. There is no single test or imaging finding that can diagnose. Studies have shown that experienced providers can predict the presence of endometriosis based on history and physical examination in 80% of cases. So if a provider is suspecting endometriosis is present, they can start empiric treatment for management without resorting to surgery first. It is not often that you will feel cysts, nodules, or a fixed uterus with a bimanual exam. And just because you may not feel or note these things does not mean that endometriosis is not present. And there's no individual serum marker that has been sensitive or specific enough for diagnosing or monitoring of endometriosis. Blood work is sometimes not as revealing as you would hope, And this is likely because what is happening in the serum is not reflecting what's actually occurring at the tissue level. On average, it takes 8 to 10 years for women to get a diagnosis of endometriosis. That is way too long for them to be living with those symptoms without treatment. Also, for diagnosis, consider imaging such as transvaginal ultrasound or MRI. They may be helpful in identifying endometriomas and deep infiltrating endo. Neither transvaginal ultrasound or MRI have been first line tools in the diagnosis of superficial peritoneal lesions, although there are some new transvaginal ultrasound saline infused techniques that may be helpful in identifying those superficial peritoneal lesions. Transvaginal ultrasound is considered the first line for imaging over MRI. MRI is not reliable in diagnosing pelvic adhesions or superficial implants, although MRIs may be helpful with differentiating unclear pelvic masses and lesions on the ureters, bladder, and bowel. If the healthcare center does not have an experienced or specialty trained transvaginal ultrasound technician available, MRI may be considered. Or you might consider an MRI if the symptoms are highly suggestive of deep infiltrating endo and the transvaginal ultrasound findings were negative. The gold standard for diagnosis of endometriosis is a laparoscopic visualization. However, it is no longer a requirement if the provider highly suspects endometriosis is present and wants to initiate treatment first. They can do so. Unfortunately, if treatment fails, the patient may still need a laparoscopic procedure. 15 to 20 years ago, they required a biopsy for diagnosis. Things may be shifting away from the requirement in more recent years. The only way to stage the severity of endo is through surgery, and it's based on the points given on the size, location, and severity of the adhesions. It's given a stage of 1 to 4. Unfortunately, with the staging system, it has shown little to no correlation with patient outcomes. The severity of the staging or disease does not always correlate with the symptoms or even the ability to get pregnant. And there's no international agreement on how to classify or stage endometriosis. These are just some of the many reasons why patients and providers are opting for empirical treatment prior to considering surgery. What if the patient does need a surgery? Maybe it's based on certain symptoms or findings on imaging or concerns for infertility. Then there is the decision of what type of procedure is going to be done. Should they go all in and cut it all out with excision techniques, but then they risk possible more scarring or tissue damage? Or should they do an ablation technique? And if so, what technique is available, laser or argon? Laser may be better for those deeper lesions, but it may not get all the endometriosis and has the potential for damaging surrounding tissues. Or you could use the argon beam technique. It's a little more superficial and less likely to damage surrounding tissues, but then may not get all the endometriosis. Some studies show greater improvement with ablation techniques versus an excision approach. Other studies show no major differences between the two techniques when treating mild to moderate cases. Both laser and argon beam need someone specifically trained in those techniques. Laparoscopic surgery and impacts on fertility. There are some concerns regarding fertility after excision of endometriomas. So if you're already having a patient struggling with infertility and they have low AMH levels, you might hit the pause button before proceeding of removal of endometriomas, depending on the case. There is some research showing that AMH levels drop after surgical management of endometriomas, indicating a decline in ovarian reserve. So these are just a few additional things to kind of consider in your treatment plans and future family planning options with patients. Take some of these things into consideration. Using the Dutch testing in your endometriosis workup. Yes, you can use the Dutch testing as part of your workup for evaluation. It's convenient, it's non-invasive, and you can use the findings to identify problem areas and select treatment options that address unique needs of each patient. The Dutch test can often see patterns associated with inflammation, oxidative stress, poor estrogen detoxification, imbalances in hormones, and preferences for certain problematic pathways. Even though serum and urine results can look similar for women with or without endometriosis, sometimes we can see these patterns that are present and they kind of show themselves or give clues into areas that can be optimized for overall health improvement. Serum and urine hormones are complementary. They are looking at things from different angles. Serum is kind of showing you what the hormones are doing on their way to the tissues, and urine is showing how the body utilizes them, then metabolize the hormones out. In urine, you're going to get an average of hormone levels over hours of time versus serum is a single point in time. And if you happen to check serum during a time when levels were either peaking or at their trough, you might be missing some valuable information. Urinary markers for estrogen metabolism and endometriosis. There are some small studies out there that are starting to focus on the metabolism of estrogen by evaluating urinary metabolites and its impact on endo. We test for these same markers on our test, on the Dutch test. We test the 2-OH, the 16-OH, the 4-OH, and more. This helps to evaluate for abnormal estrogen detoxification pathways in both phase 1 and phase 2. When running a urine test, some of the things we're looking at are imbalances in the 2 to 16-OH balance and the 2 to 4-OH balance ratios, which is part of phase 1 detoxification. We also look at phase 2, which is the methylation of estrogen metabolites to see if there's any issues with clearance. If there's an impairment in phase 1 or phase 2 pathways, kind of think of it as like a sluggish estrogen clearance. Maybe there's like a clog in the drain is another way of describing it. And these could contribute to symptoms. So looking at the urinary markers can be helpful, and it can help guide you to tailor your holistic treatment plans and optimize areas of concern. I didn't list the study here, but a study by Javier in 2013 studied women with ovarian endometriosis by looking at biopsies, and they found imbalances between phase 1 and 2 estrogen detoxification, which resulted in excessive 2 and 16-OH estrogens. Although those were not urinary samples and they were biopsies, it still gave insights to impaired estrogen detoxification as one culprit. We have lots of free resources and webinars on our website that help deeper dive into these metabolites and ways to improve the detoxification pathways. There are lots of things available to you that you can use to help fine-tune treatment plans for better outcomes and just overall health of the patient. We also have some additional resources for providers that are signed up with Dutch. We have a mini guide specifically related to endometriosis. I hear from providers all the time that they enjoy this checklist. They often have the report and the checklist next to each other, and they go through the report and they check off the markers or patterns they see. It can kind of help you narrow your focus and guide treatment selections to areas that need the most focus or maybe need to take priority. For example, let's say you get a report back on a patient with either known or suspected endometriosis, and you have a checklist in front of you, and you notice these patterns on her test. It shows a poor phase 1 and phase 2 estrogen detox. Maybe there's a high 5-alpha reductase, which is typically associated with underlying inflammatory conditions. Maybe you see a high kynurenate, a B6 marker noted on our oats page. It can also be associated with inflammation. And maybe a high pyroglutamate, also on the oats page, and can be an indicator that she may be lacking in her master antioxidant of glutathione. These are all strong areas that can be focused on in your treatment plans to help optimize symptoms and help get control of endometriosis. Let's look at some cases. We commonly see these during our consultations, our clinical consultations with providers. Here's one what many might call a classic case because they think it kind of fits the typical bill and the results look like what the provider was expecting. This report here is of a 30-year-old diagnosed with endometriosis, confirmed, reports regular cycles and complaints of estrogen excess symptoms. This is the presentation here that a lot of providers are kind of expecting to see. They'll see estrogen is spiking above range in the late follicular phase and then remains high in the luteal phase. We see high end or above range estrogens in the luteal phase. This contributes to the estrogen dominant picture that many expect to see in endo. We see high end and above range estrogens in the luteal phase. This contributes to the estrogen dominant picture that many expect to see. We see a poor phase 1 estrogen detox with this report. Phase 1 is kind of like turning on the sink. Did those estrogens go down the right pipes? The 2 to 16-OH balance and the 2 to 4-OH balance sliders are less than favorable here. We want these sliders to ideally be in the green zone. That's where the majority of the healthy population falls. We want them to be favoring the 2-OH. We don't want them to be favoring the 16 or the 4. The 16-OH is associated with more proliferative side effects like heavy bleeding, fibroids, PMS, endometriosis. And the 4-OH is associated with oxidative stress and DNA damage. The phase 2 detoxification on this report looks good. That's that methylation activity I mentioned earlier. But this is another pattern that you want to assess in your patients to ensure proper estrogen detox is occurring. Although her androgens were within normal limits for her age range, she appears to have a high 5-alpha preference. A high 5-alpha can be associated with underlying inflammatory conditions and can drive up that enzyme, making things feel more androgenic. So kind of be thinking about things like autoimmune issues, obesity, alcohol, insulin resistance, maybe even gut dysbiosis that could be creating underlying inflammation. Work on those underlying root causes to get inflammation down, and that will help so you're not driving up that 5-alpha so much. Here's another example of what some might call a classic case. This is a 26-year-old normal BMI, confirmed diagnosis of endometriosis. She reports regular cycles and complains of estrogen and androgen excess symptoms. Again, I say classic because this is what patients and providers expect to see when they do the test. They see this robust hormone picture with estrogen and sometimes even with the progesterone. But relatively speaking, with this profile, even though both the estrogen and progesterone are robust, the estrogen is still relatively higher than the progesterone, contributing to that estrogen dominant picture. We see high end or above range androgens, which can also lead to higher estrogens due to increased aromatization. We can take our androgens and aromatize them over to estrogens, making the imbalance even worse. We can also see here again that she has that high 5-alpha reductase. So be thinking about those underlying inflammatory things that could be driving up both the aromatase and the 5-alpha reductase with this picture. Although on this report, she does have good phase 1 and phase 2 estrogen detoxification patterns. So that's a good thing for estrogen clearance, but she still looks pretty out of balance in other areas. But what happens when the results don't look like this? We get a lot more calls about these types of results because it's not what the provider was expecting. In fact, things look fairly good here, and we're not seeing estrogen dominant picture, and the estrogen detox patterns look good. The androgens are normal, and there's no strong 5-alpha preference. The other markers, which are not shown here, but the cortisol patterns, the oxidative stress markers, and other inflammatory markers were all normal for this profile as well. This is a 32-year-old, regular cycles, normal BMI, confirmed endometriosis. But how can this be? There's nothing jumping out here, and providers call in asking how that can be if the confirmed endometriosis and they're symptomatic. This is what makes endometriosis so tricky, or like I called it earlier, a mystery menstrual mess. It doesn't play nice. It does not always present the way one would anticipate. And whether it's in serum, urine, or even laparoscopic visualization of the findings, sometimes it's just not presenting the way you would expect. And because there are many layers or factors or pathways even involved in endometriosis, if we are only addressing what we see in the serum or urine and not addressing multiple factors or pathways, we could be missing opportunities for better management of patient symptoms. This is just one example that hormone levels are not addressing what's occurring at the receptor sites of the tissues. And even though serum and urine results may fall into what we call normal ranges, there can be dysfunction at the tissue level, creating an imbalance. And these tissues are behaving much differently in women with endometriosis compared to women without. Hormonal imbalances, just the one of many factors. We're going to dive into some research related to progesterone resistance and its role in endo because it can impact approaches to treatment. It's not as commonly talked about in comparison to estrogen dominance when we're referring to endometriosis, but it's sort of a disservice to the patient if you're only focusing on one aspect when there are many more things at play and they are occurring simultaneously. This is part of your crime show documentary where you start to kind of piece some of the puzzles together and you start seeing how many things are interconnected. And I really do think endometriosis is a crime on women because it can be so debilitating for some. Progesterone controls the transition of the endometrial lining from a proliferative to secretory state. So this graph here is showing you kind of just your typical fluctuations that you would see in a normal cycle. Essentially, progesterone is switching the endometrium from a growing state to a receptive state for potential pregnancy. In endometriosis, though, the tissues are behaving differently and the progesterone receptors get all messed up. And then we get this problem with the growing state kind of switching over to a receptive state. Just a little quiz time. How many of you knew that progesterone levels are low in the follicular and ovulatory phase? And progesterone only rises in the second half of the cycle after ovulation during the luteal phase. Progesterone rising in the luteal phase is also associated with the secretory phase that is occurring in the uterus. That is why collecting samples, whether it is in serum or urine, you want to try capture progesterone testing in the luteal phase when it's supposed to be peaking. This is on average typically around day 21 of a normal 28-day cycle, give or take a few days, depending on each individual cycle. Many times providers or patients are not paying attention to when the patient is getting their testing done, and she may be in the wrong time of her cycle. Then she is told her progesterone levels are really low when really she just tested on day 7 of her menstrual cycle when progesterone was supposed to be low and it wasn't even her luteal phase. So timing is going to be important if you want accurate progesterone levels. What is progesterone resistance? This is what our main focus is on today. Progesterone resistance does not mean that you are not making enough progesterone. Serum progesterone has no significant differences in endometriosis versus healthy controls. It means there's a dysfunction or dysregulation at the local tissues, and proper progesterone signaling is altered, which leads to a decreased progesterone action, and the endometrial tissues behave differently. Progesterone resistance has been noted in the endometriotic tissues found both in and outside the uterus of women with endometriosis. Progesterone resistance is the dysregulation of progesterone signaling combined with endometrial tissue's inability to appropriately respond to progesterone exposure. So let me try to simplify that a little bit. The signal is not working, and even if progesterone is present, the tissues do not respond appropriately. We need proper progesterone signaling to counteract estradiol's effects on the endometrium. We need it to help us switch that endometrial lining from a growing state to a receptive state. The loss of progesterone responsiveness leads to both an increased growth of endometriosis lesions and a non-receptive endometrium. Progesterone receptors. Inside the nucleus of the cell, progesterone binds to progesterone receptors. There are 2 main types of progesterone receptors. There's progesterone receptor A and progesterone receptor B. How progesterone is expressed will depend on which receptor it is binding to. The progesterone receptors have similar binding activities to progesterone, but different roles in how the effects of progesterone will present. To try to simplify that a little bit, imagine if you had a master key that can unlock multiple doors and you use that key to unlock 2 doors. The master key maybe opens up one door to a living room and then the door to a different room, which could be like a storage room. And the keys works on both of those locks, but you get 2 different outcomes. Progesterone kind of fits on both of those receptors, but the actions of those receptors are going to be different. Both natural progesterone and synthetic progesterone actions are controlled by these progesterone receptors. This diagram is showing you how the endometrial lining goes from a growing state to a receptive state and helps to give a visual of the different fluctuations in progesterone receptors throughout a normal healthy cycle. The endometrium expresses both progesterone receptors A and B during all phases of the menstrual cycle, but they do follow a cyclical pattern throughout the menstrual cycle under the influence of hormones like estrogen and progesterone. In endometriosis, studies indicate that the progesterone receptors lose this cyclic pattern seen in normal menstrual cycles, and there's no longer this nice coordinated rhythm or ebb and flow like seen in healthy endometrium. The progesterone B, or progesterone receptor B, is often low or even undetectable, and progesterone receptor A is more predominant. Part of the hormonal alterations that occur in the tissues and endo are how progesterone receptor A and progesterone receptor B are being expressed. Progesterone receptor A and B are considered opposing systems for target cells to control progesterone responsiveness. Progesterone receptor B, which helps promote progesterone signaling, which is the key in keeping that balance between estrogen and progesterone and helping that endometrium from properly switching to a growing state to a receptive state needed in that second half of the cycle. When there is a progesterone A dominant state, it decreases the progesterone responsiveness. So the higher the ratio of A to B means there's more progesterone receptor A being expressed relative to progesterone receptor B. Biopsies of endometriotic tissues showed a lack of progesterone receptor B receptors, and progesterone receptor A was present in all the lesions. So remember, when you have a progesterone receptor A dominant state, it means there's a decreased progesterone responsiveness. Progesterone receptor B also experiences hypermethylation. So progesterone receptor B is also affected by genetics and epigenetics due to that hypermethylation. And hypermethylation is an increase in DNA methylation, and that can lead to a reduced expression of the gene. If there is a reduced expression, that means there's less progesterone signaling going on. In endo, it affects only the progesterone receptor B and not the progesterone receptor A, leading to a disproportional expression of the two progesterone receptors. The mechanism of action of why progesterone receptor B, is being hypermethylated is unknown, but it is suspected to be a result of chronic inflammation, increased pro-inflammatory cytokines, and abnormal expression of microRNAs. Just a brief recap of how progesterone receptors play a role in progesterone resistance. A higher progesterone receptor A to B ratio in the endometriotic tissues of endometriosis, it leads to a progesterone receptor A dominant state. And when you have a progesterone receptor A dominance, it decreases progesterone responsiveness. And we also have this progesterone receptor B that's undetectable in the endometriosis lesions, which leads to a lack of progesterone signaling. And the progesterone receptor B hypermethylation leads to a decreased gene expression. I thought estrogen and progesterone were friends. We've only been kind of talking about progesterone resistance so far. Estrogen and progesterone are supposed to be buddies. They were meant to go together. They are supposed to fluctuate together and each play an important role in relation to one another. But are they friends when it comes to endometriosis? Does estrogen dominance contribute to the progesterone resistance? Or does progesterone resistance lead to estrogen dominance in the tissues? The answer is yes to both of those questions. Let me explain. First, let's review estrogen's role in endometriosis. In endometriosis, we see an increased estrogen receptor activity in the tissues and a decreased progesterone receptor activity. This further creates that discrepancy between estrogen and progesterone balance. We see an overproduction of E2 in the local tissues, and this drives up estrogen receptor beta signaling. Estrogen receptor beta triggers pathways that enhance lesion survival and remodeling of the tissue, increasing inflammation and stimulating pain receptors in the pelvic tissues. Remember, this is occurring at the local tissues, this overproduction of E2, and studies have shown that serum levels of E2 are not significantly different in endometriosis versus healthy controls. So this is happening locally. Or more simply put, the circulating hormones may be normal when the tissues are promoting local estrogen dominance. Local E2 levels are increased due to an increase in aromatase activity and a decrease in 17-beta HSD2 activity. Aromatase increases the conversion of androgens to estrogens. So if you have someone with high androgens or someone with high aromatase activity, it can contribute to an estrogen dominant state if they start pushing their androgens over to the estrogens through that aromatase activity. This is happening at the local tissues, but if I see high androgens, whether it's in urine or serum, it does kind of make me start to think about what might be happening at the local tissues as well. Estradiol stimulates the production of prostaglandin E2 or PGE2. In endometriosis, levels of PGE2 in the peritoneal fluid is significantly higher compared to women without endo. It is thought to be one of the factors that contributes to the growth and survival of endometriosis lesions. And prostaglandins contribute to pain and inflammation, which is why NSAIDs are the most commonly used pain management to help with pain. They can inhibit prostaglandin production. And the PGE2 also further stimulates aromatase activity. So PGE2 and E2 in the lesions appear to suppress progesterone expression, leading to a loss of progesterone action and progesterone resistance. All of these factors are allowing for higher amounts of local E2 production. Let's review. We have this aromatase activity that's creating more E2, and the E2 is stimulating the PGE2, and the PGE2 is increasing aromatase even further, and now you have even more local E2. And with all this E2 and PGE2 around, it suppresses progesterone expression and leads to progesterone resistance and decreased progesterone activity. So back to one of my previous questions when I asked, does estrogen dominance play a role in progesterone resistance? Yes, it does. We need proper progesterone signaling to induce the 17 beta HSD2, but in endometriosis, progesterone is incapable of inducing that 17 beta HSD2 expression due to a defect in the stromal cells. We need 17 beta HSD2 to help convert the potent E2 to the weaker E1. So taking your estradiol and converting it over to your estrone. But because we have an impaired progesterone signaling going on, it can't kickstart that cascade of events for the 17 beta HSD2 to express itself to its fullest. The decreased expression of 17 beta HSD2 results in the inability to inactivate E2. To try simplify this, the progesterone receptors are impaired, so the signaling to the 17 beta HSD2 becomes impaired because it's supposed to be induced by progesterone. Decreased 17 beta HSD2 expression, it's decreasing the 17 beta HSD2 expression, and the tissues then struggle to inactivate the E2. This answers the question I had earlier. Does progesterone resistance contribute to estrogen dominance? The answer is yes. And again, estrogen and progesterone are not being friendly. They are behaving much differently in endo than in normal healthy endometrium. This is just a recap of the local estrogen production in endometriosis. It's a table to just kind of recap the concepts we just chatted about and helps to lay out different mechanisms at play that contribute to the endometrial lesion growth. You can come back and look at this slide later for a refresher if you need to. In other words, we have this decreased progesterone receptor signaling and responsiveness, and it cannot counteract the E2 actions, which allows then for higher amounts of local E2 production. Estrogen and progesterone were meant to be buddies. They were supposed to be together. They were supposed to helping each other out, but that's not the case in endometriosis or in endometriotic tissue. They are out of sync, and progesterone receptors have kind of turned their ringer off. They've muted their text messages. They've silenced their email notifications, and estrogen keeps getting louder and tries to sneak around. It's trying to slide into the DMs and the emails or whatever means that's trying to do, but progesterone just remains unresponsive and leaves estrogen kind of on red. At this point, I wish progesterone would just fight back a little and kind of just block the estrogen, and then maybe estrogen would quiet down a little bit. There are other factors that contribute to progesterone resistance more than just the progesterone receptors. So genetics, inflammation, altered microRNA and epigenetics, environmental exposures, defective stem cells, they can all also contribute to that progesterone resistance. If progesterone resistance is a factor, then why are progestins, which are synthetic, first-line treatment? Both natural progesterone and synthetic progestins are mediated by progesterone receptors. Progestins are synthetic and have a longer half-life than endogenous progesterone. Progestins and progesterone have different impacts due to different chemical structures, metabolism, pharmacokinetics, and binding affinities. They're not the same, therefore they will not behave the same. Although 1/3 of women globally remain symptomatic with progestin use. A study by Flores in 2018 showed patients that did not respond to progestin-based therapies had significantly lower progesterone receptor levels than those that did respond. The progesterone receptor status is going to be important on whether or not she's going to get an adequate response from that progestin therapy. There are different types of progestins as well. 3 major groups are based on their structural properties. So if you have a patient that's tried one progestin from one category and it didn't work, it may be worth trying a progestin in a different category to see if you get better results because they have different structural properties. So one might work better than another. The mechanisms of the hormonal treatments. There's many different type of hormonal treatments out there, and they all have different mechanisms of action. Some are working on the HPO axis or direct effects on the endometrium to blocking androgen aromatization. It's very complex, as is endometriosis. Therefore, some treatments will fail and others will work quite well depending on the patient's individual factors. It is not unheard of for more than one hormonal treatment to be used at the same time in endometriosis if one was not well controlled, if they weren't well controlled on one. And sometimes you have to play with the types, routes, and dosing. Why not use natural or micronized progesterone instead of progestins? I personally prefer to use natural progesterone options over progestins when possible. However, when it comes to endo, the tissues are behaving differently than the normal tissue, and responsiveness does not always work with natural or micronized progesterone, depending on the patient. And I'm not saying that you can't try or use it, just that you may experience higher rates of failure compared to the progestins, depending on the individual makeup of the patient. Or you may have to use much higher doses than you typically do to get an adequate response. Micronized progesterone is often used cyclically, and this does not suppress ovulation. Typically, the therapeutic benefits from hormonal treatments used in endometriosis comes from the suppression of ovulation. So if you're using a micronized progesterone, sometimes you have to use it with another treatment modality that maybe is also simultaneously suppressing ovulation. And some patients want to use the micronized progesterone cyclically in the luteal phase of their cycle for fertility benefits. They don't want to suppress their ovulation with other hormonal treatments available because they're trying to get pregnant, or maybe they're using it for other purposes. But there is limited research on showing cyclic progesterone being able to help control endometriosis. It might be helping with fertility in a different way, but it might not actually be controlling the endometriosis per se. We do need more research in that area. Many providers that manage endometriosis report having to have much higher dosages than what is used in HRT to see some benefits. And I had a hard time finding any safety studies that regarding dosing for oral or vaginal routes needed for endometriosis control. Although I would love to see a good study about vaginal progesterone use and its outcomes with endo. Because we are seeing good results with the progestin IUDs, I think it has a lot to do with the hormone being right at the uterine site. So that's why I'd like to see a good study about vaginal progesterone and its outcomes on endometriosis. And maybe possibly vaginal progesterone could get similar results if it was bathing that endometrium due to the vaginal uterine first pass effect. I just don't know. Part of the reason why oral micronized progesterone, or OMP, may not be getting the same results as progestins is because of a rapid pharmacokinetic profile. Serum progesterone levels rapidly rise and fall within hours after taking OMP, and progestins have a much longer half-life. OMP use in HRT does protect the endometrium, but because tissues behave differently in endometriosis compared to healthy controls, it is hard to say if OMP is helping control or manage endometriosis at this time. I think this is going to be patient specific when it comes to outcomes. It might work great for some, and others, they might still get breakthrough pain and symptoms. Vaginal micronized progesterone. It has been proposed that there is a direct vaginal uterine first pass effect of progesterone. If vaginal micronized progesterone is placed in the upper 1/3 of the vagina, this could lead to a higher uterine concentration, more than what might be reflected in serum or urine. The vaginal micronized progesterone is getting right to the endometrium. I'd like to see more studies on this route, but I think it could be promising for some individuals. There is research out there for vaginal progesterone use and infertility. And there are even studies in women with endometriosis and infertility and vaginal progesterone use. So I still think it's worth noting some routes of administration may have better outcomes. But what the studies don't address is if it is actually controlling the endometriosis, or is the vaginal micronized progesterone controlling other factors, and that is why pregnancy rates improved. Transdermal progesterone may not be the best route of administration for management of endo. Some of you may have had patients that tried transdermal progesterone but still reported symptoms. And this may be because it's not getting to the endometrium or having enough of a positive impact on the endometrium. In HRT studies, they have found that transdermal progesterone use may not protect the endometrium as much as one would hope, making oral micronized progesterone or vaginal micronized progesterone the preferred route for endometrial protection in HRT use. I'm hypothesizing here, but if transdermal progesterone is not protecting the endometrium in HRT use, is it possible that it is not able to get the right endometrial activity we want in endometriosis as well? It's just a thought. Some common treatments. Okay, now what? You've got a patient with endometriosis, whether through empirical diagnosis or confirmed surgical. but what treatments are you going to use? And it's all going to depend on the wishes and needs of the patient, immediate or postponed family planning needs, severity of the symptoms, quality of life, and so forth. But there are options. This table here reviews the list of the most common approaches for endometriosis management. It ranges from first, second, and third line treatment options and most common side effects associated with these routes. It ranges from NSAIDs to cyclic or continuous OCPs, different types of progestin IUDs, gonadotropin releasing hormone agonists, and danazol. Some are not FDA approved and are considered off-label for endometriosis. For instance, the levonorgestrel IUDs are not FDA approved in the United States for endometriosis management, although they've been gaining lots of traction over the years for off-label use because they're doing a fairly good job at controlling symptoms for many women. The 52 milligram IUDs are approved for up to 5 years for heavy bleeding and 8 years for pregnancy prevention. Many women with endometriosis are needing them to be replaced on average about every 2 years. Some are much shorter, like every 8 months, and others can go longer, like 3 to 4 years before breakthrough symptoms occur. The 3.5 and the 19.5 milligram levonorgestrel IUDs have not been studied with endometriosis. However, in my experience, they did not seem to control symptoms to the same degree as the 52 milligram IUD did. And if someone's going to go through the procedure to have an IUD placed, I'd rather have them use the 52 milligram dose as they tend to get better control. Those using gonadotropin releasing hormone agonists such as Lupron, which is an injection, or Orilissa, an oral gonadotropin releasing hormone antagonist, it puts the patient into a hypoestrogenic state, although they tend to come with a lot of side effects. So some are finding that they're using add-back therapy with norethindrone acetate, also called NETA, and that can lessen the symptoms. Although bone loss is still a concern for those agents. So make sure you're reading the package inserts on those types of medications for length of use and when to stop them. They're not meant for long-term use due to the side effects. Orilissa was not listed on the graph on the prior slide. However, it is an FDA-approved medication for treatment of moderate to severe pain with endometriosis. It is a gonadotropin-releasing hormone antagonist and works by inducing a hypoestrogenic state. Lupron and Orilissa have different mechanisms of action, but ultimately they both end up suppressing FSH and LH and affect ovulation and reduce the production of estrogen. Myfembree is not listed on the graph on the previous slide as it's a newer treatment that became available in 2022. It's a combo of the gonadotropin releasing hormone antagonist, estradiol, and NETA. I don't have much experience with this one, and I haven't had patients on it currently for me to give you much feedback on it, but it is an option, and it seems that they are trying to control for some side effects by adding the estradiol and the NETA. This one also came with some bone density concerns as well. Okay, but that progestin treatment did not work. What now? So maybe trying to change the type of progestin. Remember, there was different categories. Maybe switching from a cyclic OCP to continuous. Maybe switching the routes of administration from an oral to an IM to vaginal to IUD. Maybe switch regimens. Maybe they were on a progestin-only pill, and now they're going to go to a combined estrogen progestin pill, maybe an IUD. Combining therapies, maybe they're using an IUD with a NETA add-back therapy. Make sure they're working on other factors. Are they working on their immune system, decreasing inflammation, decreasing oxidative stress? A multi-systems approach is going to be key for these endometriosis patients. Maybe include a GI workup, pain management if needed, pelvic floor rehab, acupuncture, incorporating diet and lifestyle changes are going to be important. What about other treatments to consider if 1/3 of women do not respond to progestins? This article is worth checking out if you want to further understand new therapeutic treatments that can target other factors involved. It went into quite a few different target areas. Some investigational therapies that are out there, aromatase inhibitors like letrozole are not FDA approved in the US for endo, but they are considered a third-line treatment option. Their action is based on the reduction of local estrogen and prostaglandins by decreasing that aromatase activity, although they do come with a kind of a hefty side effect profile. Some studies are kind of exploring recommending maybe using it with add-back therapy with norethindrone acetate, or using it in combination with your combined oral contraceptions or progestins or gonadotropin releasing hormone agonists. Metformin is under some investigational studies as a treatment option for endo, and there are some promising results coming out from these studies, although we do need some human studies. But in these investigational studies, they found that it was inhibiting PGE2, which decreases that aromatase activity, which is really good. It's decreasing inflammatory markers. It inhibited the growth of new vessels. It was associated with lower adhesions. It had positive effects on the gut microbiome. So this one's going to be interesting if the human studies show the same. Low-dose naltrexone, or also known as LDN, is on the rise for off-label use in endometriosis. It's not FDA approved for pain associated with endo, but it is showing some promising results with reduction in pelvic pain syndrome without compromising fertility. So this is starting to be on the rise a little bit as well with your endometriosis patients. Find some targeted therapies. When you're doing your workup for endo, you can learn to apply the pressure of markers that are problematic, especially if you're seeing areas that need to be optimized to support the immune system, decrease inflammation and oxidative stress. Anytime you're working on inflammation, you're working on endo. Anytime you're working on the immune system, you're working on endo. Anytime you're working on oxidative stress, you're working on endo. Find therapies that will help target these areas. Curcumin. Here are some examples of things that could work or to consider adding into your current treatment. Get after that immune system. Think about things that can decrease cytokines and inflammation. Curcumin has many benefits in the body, but a decreased expression of VEGF can be beneficial in women with endometriosis. We don't want those endometriotic lesions growing and getting new blood vessels. This is a good option. Also, working on some antioxidant and inflammation support can be helpful. This study was not human studies, but these nutrients are commonly used every day by humans. The combination of NAC, ALA, and bromelain showed promising anti-inflammatory properties in endometriosis in animal studies. NAC, a very common nutrient. It's a precursor that leads to our master antioxidant glutathione. NAC is a powerful antioxidant. In this study, they took 600 milligrams, 3 tablets a day for 3 consecutive days in a row, and repeated it for 3 months. It showed a significant improvement in painful cycles, painful intercourse, and chronic pelvic pain. The participants also noted a decrease in NSAID use, and the size of endometriomas was decreased as well. And 39 out of the 52 patients that wanted to get pregnant were pregnant within 6 months of therapy. It's pretty awesome. Gonna go back there. Combining vitamin C and vitamin E to hit some antioxidant support is another great option. It's tolerated well, and it had significant improvements in pelvic pain, painful cycles, and painful intercourse. You got options, so use them. EG-CG studies have been shown to have properties that suppress cell growth, inhibit formation of new blood vessels, slows down the progression of fibrosis, and promotes cell death in endometriosis. It has also been shown to improve painful cycles. If you have other methods that are failing, try add in some of these other options or use in conjunction with treatments that you're already doing. PEA combined with trans-polydatin showed improvements in pain associated with the menstrual cycles and chronic pelvic pain. PEA and trans-polydatin have been shown to have anti-inflammatory and antioxidant effects. And PEA has been noted in some studies showing effectiveness in treatment in neuropathic and inflammatory pain as well. Melatonin is some really good stuff. It's known for its antioxidant properties. In this study, melatonin 10 milligrams for 8 weeks showed a decrease in daily pain scores, painful cycles, it improved sleep, and it reduced the need for additional pain meds. Ginger is a great tool. What a great option to include for your pain control, especially if someone does not tolerate NSAIDs or has concerns of its side effect profile. It was shown to be equally as effective in reducing pain as NSAIDs. Ginger 500 milligrams 3 times a day, starting 2 days prior to the cycle and through the first 3 days of the cycle, had significant impacts on pain control. Acupuncture. Don't forget to add in other modalities like acupuncture. Acupuncture and endometriosis reduced painful cycles, shortened duration of pain experienced during cycles, improved pelvic pain, and overall well-being and quality of life scores. If you get an endometriosis patient, try to encourage some of these other modalities for better success and better control of symptoms. Pelvic floor therapies. Find a pelvic floor specialist, a pelvic floor PT, or maybe a urogynecology office that works with endometriosis and see if they offer any of these services listed here. Research has shown improvements in pelvic pain, painful intercourse, and improvements in quality of life when using these modalities. When I worked in the urogynecology practice in the past, they had a pelvic floor therapy program there, and we used modalities like biofeedback, which is similar concept to the TENS, and a therapeutic ultrasound. And we saw improvements in symptoms often in these patients, and they were so relieved that something was finally working for them. Gut dysbiosis and endometriosis. Repair that microbiome. Don't forget to look at the gut. Are they having healthy daily bowel movements? Is there a healthy gut integrity? Have them follow up with a functional GI specialist that can evaluate for sources of inflammation, infections, markers related to impaired gut function that can alter estrogen metabolism. Do they have healthy diversity scores? Don't forget to look at the gut. I'm going to skip over these slides because today's focus was on progesterone resistance. But if you want some more information about how the immune system is a factor, I left these last two slides in here so you can come back and look at them later if you feel inclined to. We already reviewed some treatments on previous slides that can help support the immune system. Here are some other Dutch resources on endometriosis that can be found on our website. These are fantastic resources to get familiar with as they kind of really help to broaden your understanding of endometriosis and why a multi-system approach is necessary. Endometriosis, in summary, is a multifactorial disease with involvement of genetics, immune, hormone, and environmental factors. Endometriosis is both an estrogen-dependent and progesterone-resistant process. The endometrial tissues in women with endometriosis behave very differently than women without. Not all progestins work the same. Natural progesterone may not work as well in endo due to the progesterone unresponsiveness in the tissues. This is going to be patient-specific. Consider a multi-system approach for treatment plans. This is going to be very important. You want to try hit things from multiple angles and keep studying the various theories involved for better management. As we continue to push forward in research and clinical care, it is crucial to remain focused on improving diagnosis, stopping progression, and offering better treatment options that address the unique needs of the patient. My hope today is that even though endometriosis still remains somewhat of a mystery due to there not being a specific factor known to trigger the disease, I hope that you leave here today with a better understanding of some factors involved and how you can try and improve quality of life for those affected by endometriosis. Thank you for your attention and engagement throughout this presentation. I hope you enjoyed it. My references are included at the end of the presentation, so make sure to download the slides if you need them. I'd also like to take a quick moment to thank the Dutch team for all of your help while creating this webinar, and the support this team gives is unmatched. I could not have done this without all of you. Much gratitude. Have a great rest of the afternoon, and we will see you next time.
Thank you, Lindsey, for this insightful webinar on progesterone resistance and endometriosis. And thank you to all of our attendees for joining us today. We hope you learned something useful. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. And you can learn more about the research behind the Dutch test at dutchtest.com/research. And make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. Be sure to follow @DutchTest and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.